I see Dr. Coker is making his way up. Thank you. Not a Leighton drummer? You're not okay. Leighton something. Your dad was a drummer. Excellent. Dr. Eric Coker, again, feel free to read in more detail in this two-sided glossy piece of paper. His background, one of the things I'll point out is his training in maternal and child health, which I assume will come into play in your talk because it does involve childcare and low-cost sensors. And I think we're seeing a theme of low-cost sensors, and personally I've sort of tipped, I guess, in my favoritism towards them, and hopefully whether or not you comment directly, it's been implied that the quality has gone to the point where they're more reliable and more helpful and becoming more widespread. So I think that's a positive development. Anyway, take it away, Eric, and thank you for your time.
Thank you, Chris. First of all, thank you for the invite to talk. Have been really fascinating and high-quality talks, and I've learned a lot, so thank you. Before I get started, I do want to acknowledge that the work that I did today was conducted on the traditional and unceded territories of Musqueam, Squamish, and Tsleil-Waututh nations, as well as the more broadly the Coast Salish people. The air sensors that I'm going to talk about and the facilities that were involved certainly represent other nations that are too many to mention right now, but I want to acknowledge that. So I guess I do have a thing to press. That's good. Here I'm going to talk about some lessons learned of some air monitoring we've been doing for a couple of years now at long-term care facilities and child care centers, child daycares, whatever you want to call them. But we've been doing a lot of air quality measurement, indoor and outdoor, and I'll talk about some of the lessons learned, the modeling that we've done, and try to sum it all up in a coherent way. This map, so the impetus of this project really is oriented around wildfire smoke and communicating health information, air quality information about wildfire smoke and air pollution more broadly. This map is showing you, this is some modeling done by Nam and Paul at the BC CDC. This map does a pretty good job of highlighting where wildfire impacts are most pronounced in BC, southern interior, central interior, if I'm saying that correctly. It's clear where we see larger impacts, but that's only part of the story. What I mean by that is, sure, we can say that people in the center of the province, their outdoor wildfire smoke exposures are going to be higher on average. There are more frequent occurrences of those fires, tend to be close proximity to those fires. But there's other considerations about in terms of where the vulnerable populations are, because we have to be cognizant of the adaptive capacity of communities, households, individuals to adapt, to take action to prevent exposure. And also, where are the sensitive populations? Who are the sensitive populations to wildfire smoke? These are other considerations when we talk about vulnerability. So it's a very complex story to tell, and so there's a lot of work done to try to understand the differential vulnerability and how we can address, come up with public health measures that are appropriate. I'm not going to unpack this busy slide here, but I do want to point out that there are some key ingredients to equitable public health measures. You want to have the measures should be evidence-based, well-targeted, effectively communicated to the populations that need to hear it. They should be well-resourced, and they should be part of partnerships, public-private partnerships, community partnerships, those sorts of things. The reason why I just highlight this is this project that I'm going to speak on really does try to touch on each one of those kind of pillars for public health measures. I'm not going to go into great depth about preventive measures for wildfire smoke because exposure mitigation, because there's been a lot of great talks in that space, and really set me up nicely to talk about my talk today. But we can all probably talk about these now in our sleep. Air filtration, ventilation, reduced outdoor activities. These are all well and good measures. Some of them have some effectiveness, some of them have less effectiveness. But the ability of people to implement these is going to be widely variable across the population and for some sensitive populations, which brings up some key health, kind of public health challenges when dealing with wildfire smoke. Our communication strategies are really challenged by wildfire smoke. It's sometimes difficult to pinpoint when and where people are going to be exposed to wildfire smoke. Ensuring that the air quality information is accurate in terms of what we expect people to be exposed to potentially, and then kind of prompting specific sensitive groups to take action. That's a very key challenge. And then, as I've already mentioned, the capacity to implement the public health measures, particularly for sensitive groups, is going to be widely variable across households, across care facilities, which is the focus of this project I'll be talking about, and across communities. There are some current initiatives at the BC CDC that we're taking part, that we've kind of led on. So Kathleen McLean, Sarah Henderson here in the room today, they produced something called the British Columbia Asthma Prediction System, or BCAPS as we call it, which tries to take kind of predictions of wildfire smoke and integrate that with health surveillance, respiratory health surveillance data, and try to kind of display for health officials, for hospitals, caretakers, for maybe the community writ large, where do we expect asthma impacts due to wildfire smoke? So this is one initiative trying to get to the where and when we expect some respiratory health impacts from wildfire smoke. We also collaborate with a lot of people that are actually in this room today to kind of give public health guidance, air quality information, wildfire smoke information, so that people can be informed, targeting sensitive populations, thinking about co-exposure to extreme heat and wildfire smoke. There's a lot of work on that space, and we try to present that publicly. And so this, BCCDC does try to do these things, and so this project that I'm going to talk about is trying to take it to a little bit more granular level in terms of a public health measure for childcare and long-term care facilities. Excuse the busyness of this graph, but there's a really important study that was done, the multi-ethnic study of atherosclerosis in the U.S. Many large cities throughout the U.S. where they've recruited a cohort, and they've been following them for a long time. And they did this really interesting study where they were interested in, what part of people's environment, if we measure their personal exposure, and we want to know, how best can we understand people's exposure to PM 2.5 or fine particulate matter of ambient origin. So the box plot on the top of this graph here is showing you personal measurements of PM 2.5 for individuals. And then the two gray box plots are showing you indoor measurements and indoor modeling of PM 2.5, and and then the green box plots are showing you modeled and measured ambient PM 2.5, so out in the outdoor environment, and then the blue box plots on the very bottom are like modeled personal exposure levels. And what they found was that measurement and modeling of indoor PM 2.5 was much more reflective of people's personal measurements of PM 2.5 exposure. So this is just to kind of highlight the fact that up to 50 to 60 and sometimes more, 50 to 60% of people's exposure to outdoor PM 2.5 occurs in the indoor environment. So we really, if we're thinking about wildfire smoke, we need to be, really have a clear understanding of what the indoor environments are like during wildfire smoke events, as was well discussed by Michael Schwant. I also want to highlight that children are a particularly sensitive and vulnerable population. What I mean by sensitive is their lungs are still growing and developing, especially children in daycares, children at preschool. Their lungs are still developing. Their breathing rate is going to be higher than adults. They're closer to the ground, so that's another source of air pollution exposure. They're often in environments like schools or child care centers where they don't really have the ability to intervene on their environment to reduce their exposure, so they're vulnerable in that sense. So this project that I'm going to talk about in particular, we have sensors at long-term care facilities, which are kind of older population, but what I'm going to be talking about mostly today is the work we've been doing in the child care centers. I also want to just reiterate or iterate the importance of indoor air quality at child care centers. There's been survey data from Canada that shows that 50% of children younger than 6 years were enrolled in a child care in 2022, and nearly a third of Canadian children attend on a day-to-day basis a child care or preschool facility. Survey data from the U.S. suggests that anywhere between 31 to 47 hours are spent per week by young children at child care facilities. And there was a study done in Seattle to show that young children spend the majority of their time indoors at daycares. So, when we think about this is, children are spending, almost as much time as they're spending at home, during the weekdays in these child care centers. So we have to be thinking about those environments. And during wildfire smoke episodes, are they spending even more times indoors? So this just kind of brings to the fore the value of kind of understanding these environments that this sensitive population is staying in. So now I'll talk about this project that is funded by Health Canada. It was initially started by Sarah Henderson, and then she kind of handed the project to me, and I took the baton. Phase one of this project, what we call the Indoor-Outdoor Sensor Project, is involve co-locating low-cost sensors indoors and outdoors at child care facilities and long-term care facilities. One of the objectives of the project, one of the main objectives, is to estimate the relationship between outdoor PM 2.5 and indoor PM 2.5 at these facilities. So a kind of really highly granular look at this at a facility level and across the entire facilities that are participating. And then we wanted to compare infiltration on wildfire smoke days and days that were not impacted by wildfire smoke. So those are the main objectives: this co-location to get this granular data, estimate the relationship of it for these infiltration estimates, and then see how it compares between the wildfire smoke days. There is a phase two of the project that I'm not going to spend time on talking about today, but it really involves developing an indoor PM 2.5 exposure model for kind of scale it up to the BC population, leveraging the data that we've been collecting now for about 2 years. And then other parts, we're going to be estimating ventilation at these childcare facilities, and we're actually right now implementing a survey to ascertain occupancy behaviors during wildfire, behavioral responses to wildfire smoke, and some building characteristics to try to understand what's leading to infiltration at these facilities and contributing to the ventilation or lack thereof. So now I'll just jump into the methods of this project. Again, we installed low-cost air quality sensors, and in particular, we used what's called air quality eggs to measure indoor and outdoor environmental conditions. So these sensors measure a variety of environmental conditions: PM 2.5, temperature, humidity. And for the indoor sensors, we measure CO2 as well, and we measure pressure. And so these eggs give us kind of minute-level data of all these environmental conditions at the same location for indoors and outdoors. One thing we tried to use a community science approach where we shipped the sensors, we identified all of these care facilities. These are licensed long-term care and child care facilities, and we sent them installation instructions, how to install them appropriately, gave them some additional information on how to interpret air quality readings from the sensors. So we really tried to do a good job of making sure that they knew how to install them, where to install them, so that we could get the most optimal quality data that we could from these sensors. This map is showing you, well, first of all, the study, the data that I'm going to be presenting on runs from August 2022 through October 2022, so the 2022 wildfire season, so not 2023, so you can, don't worry, it's not 2023 craziness. But all those red dots that you see are not the facilities. Those are wildfires that were documented for 2022. It wasn't a particularly intense wildfire season, but certainly there were wildfires and wildfire smoke impacts. For each regional health authority, you can see where those ends or the sample sizes, the number of facilities within each regional health authority, which involved Northern Health Authority, Interior, and Vancouver Coastal Health. We also created an air quality app for the facilities so that they could look at all these different environmental conditions that we're measuring, so they can see it in real time. We provide them corrected PM2.5 data at an hourly level. They can look at a map. They can look at sensors nearby in their community. What are these other care facilities? And we try to provide information about AQHI and these sorts of things. How can they interpret the data that they're seeing for their facility? They can look at their indoor versus outdoor PM2.5 levels. So like this graph is showing you this facility, what was happening indoors was very reflective of what was happening outdoors during a wildfire smoke event. But they can also look at things like temperature and humidity, and we also show them some PM2.5 infiltration in real time so they can try to understand what's happening for their own location. So now I'm going to kind of get into the nuts and bolts of how we process this data so that you can feel confident that this is pretty quality data, Chris, because I know that was a question of yours. So we have a number of QA/QC measures. So we did calibration, or we did correction of these PM2.5 measurements, and we assessed for data completeness. We did some data restrictions which are designed to address each one of these boxes that are shown here. So we restricted the data to the wildfire season of 2022, and we only analyze data Monday to Friday, 8 a.m. to 6 p.m. for these child care centers, because those are when the children are going to be present, and occupancy changes and ventilation changes during non-occupied time periods. We did something, what we call indoor peak removal, where an algorithm that identifies peaks of indoor PM2.5, and we kind of censor that data because that's a strong indication that there's a source generating PM2.5 indoors, which masks our ability to estimate infiltration. And then we define days that are impacted by wildfire smoke and not impacted by wildfire smoke using a method published by Caitlin Odell. Additional QA/QC measures, we do test the sensor pairs to make sure that they're giving similar readings. We provided the installation instructions so that as far as we know, people are installing these in uniform ways. We also have automated data quality checks where if a sensor goes down, we can try to respond to that. And then, of course, we correct the sensors using a published method from the US EPA. To estimate the relationship between outdoor PM2.5 and indoor PM2.5, so think of outdoor as your X and indoor PM2.5 as your Y. We fed a linear mixed effects regression model with a random intercept and random slope. That's a fancy way of saying, the relationship between outdoor and indoor PM2.5 will vary by facility, and the baseline levels of PM2.5 is different by facility. So this model is kind of set up, this hierarchical linear regression is set up to address that issue. We also do covariate adjustment for factors that we believe are confounders in the relationship between outdoor and indoor PM, and then we stratified the analyses by wildfire days and non-wildfire days. So I'll jump into the results as quickly as I can. This is all published data that I'm presenting on. What you see here is indoor-outdoor ratios of PM2.5 at different outdoor PM2.5 categories. And what it shows you confirms what previous studies have shown, is that as conditions become more smoky or higher PM2.5 outdoors, meaning the indoor-outdoor ratio is dropping precipitously. In other words, more smoky outdoors, it's becoming less reflective in the indoors, but there's still impacts, as I'll show you. I'll just point out this finding is consistent with other data from the Pacific Northwest showing that similar pattern. Also, Burke et al. Found that infiltration tends to decrease as, this is a study from the US using low-cost sensors, infiltration tends to decrease during more smoky conditions. This is data from our study. On the upper left-hand side, you see the indoor PM2.5. These are box plots. Just note that for the indoor PM2.5 on wildfire smoke days, there was a 235% increase in PM2.5. For the outdoor environment, there was a 229% increase. However, the indoor-outdoor ratio was indeed lower on wildfire smoke days, and the median number of days of facilities participating in our study was, for wildfire days, the median number was 13. You see the range there, give you an idea that typically during our study period, facilities experienced about almost 2 weeks of wildfires smoke. This is showing you the relationship. You can see between outdoor and indoor PM2.5, there's actually extremely heterogeneous relationships. Some facilities where it's almost a one-to-one type of relationship, and some facilities where it's a very attenuated relationship between the outdoor and indoor PM2.5, and this is a really important finding. We do find that on average about 0.56. Or you could think of it like 56% of the PM2.5 is getting indoors from the outdoor environment, but this relationship is attenuated on wildfire smoke days. In other words, there appears to be less smoke getting in or lower infiltration on days impacted by wildfire smoke. However, as that previous slide showed you, the absolute values of PM2.5 indoors is actually quite much higher than non-wildfire smoke days. One interesting finding, which was not what we expected to see, was that the infiltration tended to, on wildfire smoke days, infiltration tended to go up at commercial facilities, meaning we evaluated the buildings and kind of classified them as commercial or residential, because some of these child cares are kind of in basically residential type of facilities. So commercial facilities on wildfire smoke days, the infiltration tended to go up. But in residential facilities, the infiltration tended to go down. We think this might be related to closing windows and kind of less foot traffic of people coming in and out. And commercial facilities, these might be larger and opening opening doors or something like that could be explaining this. Our surveys that we're implementing right now are trying to address these questions. So to kind of talk about some key findings. All of the facilities experienced 3 or more days of wildfire smoke, and the typical experience for these child cares was 13 or more. PM2.5 increased by about 230% on days impacted by wildfire smoke, and about 50% of outdoor PM2.5 tended to infiltrate. However, infiltration wasn't attenuated on wildfire smoke. This was not a statistically significant finding, but on average it was lower. This is possibly due to behavioral responses to these smoky events. People are maybe, closing windows, they're changing the air exchange, that could explain this. Although infiltration tended to be increased in wildfire smoke days for the commercial facilities, which is something we're trying to understand better. But I think the most important finding is that there is really wide variation in infiltration at these childcare facilities, and this is just likely going to be explained by differences of multiple factors, human behavioral factors, and the building characteristics themselves. I do want, this is unpublished data, but this is adding on the 2023 because we now have over 2 years of data. We did find that we do see that 2023 season indeed had significantly higher indoor PM 2.5 levels. So the I guess whatever color the one that's not blue is, a gold color, that's 2023 data for the long-term care and the daycares. But the graphic on the right is showing you indoor-outdoor ratios. Again, this is unpublished data, and we have to dig into this more, but we do see that indoor-outdoor ratios of PM 2.5 at long-term care facilities tended to be very, very close to 1, which was much higher than the child care facilities, suggesting this is an important area or population we need to consider. These folks are obviously in poor health conditions because they're being cared for at these care facilities. And so probably more work needs to be done in this sensitive group. Next steps, well, we need to publish our indoor PM 2.5 exposure model, which I think will help us understand, can we do population epidemiological wide scales type of study with indoor PM 2.5. We're trying to estimate ventilation at these child care facilities, and we're doing some implementation science type research related to the 2023 wildfire season. We're asking about, the users of our app that we created. Are they using it? Are they finding it helpful for prompting behavior change for the facility? We're assessing what are the protective measures that they're taking at these long-term care and child care facilities to prevent wildfire smoke exposure for the people that they're caring for. And then we're also evaluating facility characteristics that could explain, differences in ventilation, differences of infiltration. So that survey just got deployed this week, and responses are trickling in, which is encouraging news. So we'll have more to tell on this story, I'm sure. But that's all I have. So thank you for listening, and I want to thank there was actually a lot of folks who worked on this project, so I want to thank them as well as Health Canada for funding the study. And that's all I got for you. Thank you.
You guys, you got the picture about standing out. Yeah. If you don't get a standing out, then you have trouble.
I think everybody got it right.
Okay, questions. I'm still kind of struggling with this ratio of 1.
Yeah.
I mean, that's real bad, right? So what is this? Just these are long-term care facilities that just leave their windows open? What's the idea?
Well, we don't know the answer to that question. So that's the main point of our survey is to try to understand why we're seeing these patterns. So indoor-outdoor ratios for one, for those that don't know, basically means that the air pollution that you're measuring outdoors is the same as what's happening indoors. So that suggests that maybe there's not air filtration in those facilities. The ventilation is set up in such a way that air pollution is getting indoors. So our survey is trying to we're asking the facilities what type of HVAC systems do you have, if you have one. What kind of ventilation do you use? Is it natural ventilation? What is the occupancy of these places? Are there sources of indoor air pollution? So the survey is asking those questions because sources of indoor PM also could explain, ratios close to 1. At least partially. And then, we are trying to estimate using the CO2 trait. CO2 is an imperfect tracer of ventilation, so we're applying a method to try to estimate ventilation. So we believe, after kind of going through this process of asking people what are the building characteristics, what actions are taken by facility managers to address air quality, that we'll be able to answer those questions. Questions? Great.
Okay, thanks.
Thank
Eric.
you. All right.
Thank you. Eric, take this.